Good morning. Mark, I'll let you
Okay.
start it first and then I'll.
Yeah, thanks. Sorry, getting used to where the chat function is. Good morning, everybody. Really excited to be here talking about community medicine and partnership. Both Autumn and I have been working on this and have been working pretty closely together for some time now, and it's really exciting to be here and excited about the week that's come and so giving us an opportunity to chat. We're both pretty excited about it because this is sort of our life's work. So we might go in a lot of different directions. We'll be excited to take questions and hear what you have to say. Just a little bit of my background. I'm an assistant professor in the Department of Family and Community Medicine, the vice chair for community health, and then one of the associate program directors of our family medicine residency program. So I've just been in Columbus for 2 years now. My previous 16 were in Chicago from med school on. I went to Loyola in Chicago and trained and worked extensively in federally qualified health centers on the west side of Chicago prior to joining OSU. So that's a lot of my background, and that'll probably come out a little bit in my presentation and the excitement about what's going on here at OSU and what we're doing in our department. And so that's a little bit about me.
Good morning. As Mark said, my name is Autumn Glover. I'm actually an urban planner, and so often you don't see planners working in hospital systems or working in healthcare generally, but I do believe that there's an important role to thinking about planning and the way it impacts our communities. And so we'll share a little bit about that because it really plays into the ways we're able to partner. I will say planning as a profession is really founded in both design of urban communities, but also in public health. So the first planners were really trying to make sure that the communities that people lived in were healthy. And actually a lot of planning was founded in Chicago too. So it must be a little bit of why Mark and I are so connected. I serve in a dual role here at Ohio State, both in government affairs and community relations. And so I get to think about the ways we partner with the community, including local government and different organizations, which I'll talk about in a little bit. And then I'm also serving as president of our nonprofit affiliate, PACT, Partners Achieving Community Transformation. And I'll share a little bit of the PACT story later in our presentation. And then additionally, I teach civic engagement and introduction to local government in our John Glenn College of Public Affairs. Importantly, I want to say that, we both have had a lot of great experiences, both academic and otherwise. But as we think about the context of the discussion, I really want to share something that I say with my students all the time, is that lived experience is also expertise. So I think a lot about even my own personal experiences, where I grew up, how I grew up, work experiences, and how that really adds to the lens in which I look at this work. But importantly, that also is true for the patients you serve and the community members you want to partner with. So they may not all have the same educational background, but there is expertise in their lived experience. So we'll talk more about that.
Exciting. And then I did just want to, this can be more of a conversation. We're happy to take questions in the chat box, and I'll try to see them when they pop in. But if you feel like you want to ask a question during the presentation, that's fine. Just raise your hand, and I think Rosebeen can unmute you so that you can interrupt or ask a question if you specifically didn't understand something or wanted to follow up. Hopefully we'll be able to get through all of our presentation with some room at the end for questions as well. So I wanted to just start here because this is a little bit of the worldview that that I've been living in and that we've been living in together, and so I wanted to start with just this name change and this idea of community medicine. As you may or may not have known, our department was previously Ohio State Department of Family Medicine, and we recently changed our name to the Department of Family and Community Medicine. So that is pretty consistent with a lot of academic departments across the country of departments of family medicine who are changing their names to reflect a little bit of a larger and more important mission. And so the name change really doesn't come just with semantics or wording, but really, is really purposeful and is a part of our journey. And so very exciting. And our chair, Dr. Olegwila is one of the champions, and her and I have been working through the process. So it just finally got approved, so we're pretty excited about it. But wanted to talk a little bit about what it means. You don't hear it, and if maybe the audience is a lot of medical students or others, you sort of think, well, what is community medicine? What is the function of that? And I kind of want to get into a little bit of that and the background, because a lot of what community medicine actually is in the United States really is founded on confronting racial injustice, and so I'm going to talk a little bit of the history of it, and would encourage you to learn more. We'll give you references and that at the end. But when you think about community medicine in comparison to thinking about family medicine, internal medicine, pediatrics, some of the primary care specialties that you learn about, the questions that community medicine asks are things like, what's the state of the health of the community? In practice, right? What are the factors responsible for this state of health? What's being done about it by the health system, the health service system, and by the community itself? What more can be done? What is proposed, and what is the expected outcome? And what measures are needed to continue health surveillance of the community and to evaluate the effects of what is being done? So this has its root in a lot of public health and administration, but it's deeply connected to the practice of medicine and what we do as primary care and what we do in the in our department and as family physicians. It's that idea that your patients come, we don't live in a vacuum. You might have four walls set up in a community or in a location, but we know that the health, right, is outside of those walls. So if all of your metrics and all of your focus is on what you're doing inside of those walls in terms of blood pressure management or diabetes management, but you're not looking at what is actually going on in the community around you, then you're going to be missing the mark. And we know that from the social determinants of health circle that medical care is just a small part, obviously, of the health of our patients. This actually came right, but the link is actually a publication we'll talk about in a little bit that came in 1983. So the roots are deep, and I wanted to get into that a little bit. When we talk about the social determinants of health, these two papers are some of many that sort of emphasize and drive home that point. A paper looking at housing. Individuals with inadequate housing are more likely to experience higher lead levels, asthma, and other respiratory conditions. Food insecure individuals, 20% more likely to report that they have hypertension, 30% more likely to report that they have hyperlipidemia than their food secure counterparts. So that's looking at the health of the community and asking what we as practitioners and partners can do in changing that. So a little bit of the history. I said I was going to go deep a little bit here, but I think it's important because these two individuals, in this picture, Dr. Geiger on the left there and Dr. Hatch on the right, were really instrumental in the 1960s at starting the community health center model of care. And I'll talk a little bit about federally qualified health centers, but at the time, it was really this idea of how can you practice medicine and understand that practice has to include making conditions better for the people that are living in that community, understanding it, having relationships, having partnerships, and realizing that there's a bigger role going on than just prescribing medications and seeing people in the office, which is obviously important. The roots of this are really curious. So Dr. Geiger, when he was in medical school, got in the 1950s, got a grant to go to South Africa and work with some people that were setting up at that time what would have been considered community health centers, dealing with obviously the racial injustice that had been occurring in South Africa at the time. Again, this is in the 1950s. And people were going into communities and engaging with local tribes, local villages, and giving them buy-in to the healthcare that they were wanting to provide, giving them ownership of it, and then making it more of a multidisciplinary approach, getting leaders in the community to be involved in the structure and design of the systems. And Dr. Geiger was impressed, and it sort of inspired in him this idea to come back and do this here in the United States. Dr. Hatch, being a public health expert, was on board, and the two of them, plus a couple others, really founded what we consider the birth of the community health center movement. and I mentioned that's where I worked in Chicago. But interestingly, just a kind of a tidbit, that the lived experience there in the 1960s, unfortunately, these two were pioneers and worked in the civil rights movement, but it was tricky. So the first two community health centers were based in Boston and Mississippi, and they were really, really interested in getting into Mississippi. And so at the time, there was a war on poverty declared by the president, Lyndon Johnson at the time. And the idea was that they created an office for economic opportunity that they wanted to give money to start, attacking poverty in a lot of different ways. With the deplorable conditions that were going on in the South, specifically in Mississippi at the time, and the population there, the founders pictured here wanted to get into Mississippi, but the Southern governors and the Southern senators said that we will absolutely not take any money from the federal government to do anything to look at any of our populations. We're fine. We don't want any money. And so, though the Office of Economic Opportunity was funding the money through universities, interestingly enough. So they wanted the money to kind of flow through the university structure. And when the South saw that, they said, well, we want to make sure that our universities like Ole Miss and University of Alabama get some of that funding. So we'll create, we won't veto any projects that get funded through universities. But I love this point because that actually was a back road. It was like a loophole in the system. So what Dr. Geiger and Dr. Hatch did was take the money through Harvard and create a health center in Boston, but then use that money to create a health center in Mississippi, which was not what the leadership in Mississippi wanted to have happen, but they had already agreed to the fact that they didn't have any veto power as long as it was going through universities. So it was a really big deal because that health center highlighted and emphasized the huge disparities in care and infant and maternal mortality and morbidity, and were some of the first data to kind of highlight the chasm that exists and still exists today. Thanks for letting me provide a little bit of that. Right now, community health centers are all over the place. That was the foundation. They're here. They're in Columbus. I'll show you a few. You may know them, but they're always located in areas of high need. They provide a comprehensive set of services, open to everybody, regardless of insurance status or ability to pay, which is an important thing. You can't turn anybody away. And they're patient majority governing boards. So the health centers are all made up of people that access the health center. 51% have to be made up of patients. And so it's baked into the system to have that community control, which is, I think, a huge testimony to their success. So right now, you look at health centers over the country, they care for 1 in 3 people living in poverty, for instance. Right here in Columbus, we have a few that you may or may not be aware of. Primary One Health, which is a health center that I work at, I'm contracted to. Equitas, Lower Lights, Heart of Ohio, Total Health and Wellness, which is right here, run by the College of Nursing at East Hospital, some of our great partners, and then Southeast. So these are some of the federally qualified health centers that were born out of that movement that still exists here in Columbus, providing care for patients living in poverty and others. So that's one historical portion of it, and I kind of want to look at our department, not a health center, but an academic department providing care and trying to do as good as we can in community medicine. The founders of this idea of community-oriented primary care, Dr. Fitzhugh Mullen, who recently unfortunately passed away, was one of the architects of this. So looked at what health centers were doing, looked at what community medicine is, and tried to put it into a blueprint or a playbook, and wrote this paper, as I mentioned, back in the 80s, of how you can look at doing community-oriented primary care. And a lot of the methodology was really born out of this World Health Organization Alma Ata conference in 1978 that started to really put a lot of the emphasis on the importance of primary care and its relationship with the community. So in essence, the definition community-oriented primary care is a strategy whereby elements of primary health care and community medicine are systematically developed and brought together in a coordinated practice. And so this is sort of the impetus in this idea of what we're trying to do. And again, recognizing the roots of this are in racial injustice and health disparity and promoting health equity. So when we look at some of I always like this slide because it shows that we have a lot of work to do, and there's a lot of work in promoting the ideas of community-oriented primary care and community medicine, because a lot of it requires investment. No money, no mission in a lot of ways, as Autumn and I can both talk about. But if you look here, the U.S. is in the center. This is the percentage of spending as a percentage of GDP on healthcare versus social care. You see, we spend the most in healthcare and we spend the least in social care. And I don't have a slide here that shows our health outcomes, but on the global scale for developed countries, we have some of the worst health outcomes and health disparities. So I will move this to the here and now. I've given a lot of the history of where this is born out of. I highlight this organization, the Beyond Flexner Alliance. I think it's a really good one, especially for the medical students who might be on board if they want to look into it or are not aware. Abraham Flexner, back in the early 1900s, wrote a report highly critical of medical schools for not being very rigorously based in science and in testing and scientific models, and rightfully so in a lot of ways. But his statement in his book and paper sort of laid out the way that medical education has gone on from since that point. And one of the things that he had not highlighted in that was this idea of social medicine and community medicine and the intersection. So it became a very highly scientific practice and field, and so we live with that legacy. So the Beyond Flexner Alliance, that idea of getting beyond, still including rigorous scientific review, obviously, but getting beyond that, aims to promote social mission and health professions education by networking learners, teachers, community leaders, health policymakers, and their organizations to advance equity in education, research, service, policy, and practice. So it's a big mission, and we in our department are excited about partnering with them and are always trying to get to their conferences when they happen. So I think as we look and as we talk about the roots of community medicine, why it's important for us in our department to have changed our name and to stated our mission, we look at some of the things that we're doing. Again, this is my worldview a little bit in our department, and so Autumn is going to talk a little bit more too about what the university in and of itself is doing. But we in our department, seek to create these robust relationships with health centers. I work at Primary One. We have physicians that work at Equitas and forming relationships with Heart of Ohio. We have a community care coach, our mobile unit, of which has been our Autumn and I's existence for a while, getting it up and running. And as soon as we did, COVID took over our lives. But that's a whole presentation in and of itself at some point. But the health equity curriculum and longitudinal community medicine rotations we have in our department and are creating in our residency. Partnership with the Mid-Ohio Collective Food Bank, our food pharmacy program, which came from Dr. Clark and colleagues in our department trying to get out through the system. Community health and population health dashboards that we have in our practice that helps guide our efforts across our department and our clinics. And then our Center for Primary Care Innovation and Transformation, which was created by Dr. Aliwala as she stepped into her role of chair, and Candy Magana, who's running it, really seeking to do exactly what we're talking about in community medicine, to understand what's happening in the community and where we can provide not only primary care, but a research lens and health equity lens to try to help improve the numbers that we're seeing in our communities. And then all of our work, what we've been doing with COVID-19, the Mask Up campaign, which was collaboration between our department, the Health Equity Steering Committee, of which Autumn is one of the co-chairs with Dr. Daryl Gray, Dr. Joshua Joseph, intrinsically involved in that, and then our community-based testing sites, some of the similar groups looking at how can we make sure that the patients in our community are accessing services. So those are a little, I'm talking fast, but this is a little of the things that we're doing right now to try to provide a little idea of what we're doing in community medicine for our patients, and trying to really continue to strive to be that center for community-oriented primary care. So with that, I'm going to turn it over to Autumn to talk a little bit about partnership, because I do want to say that none of this work and none of the ideas of moving to being a center of community medicine would be at all possible without a huge reliance on partnership and with people like Autumn, whom I quickly grabbed onto her coattails when I came here, and literally just said, drive me around town and introduce me to things, let me talk about what's going on. So I think I'm excited to turn it over to her to talk a little bit more about partnership.
Sure. So I will say that partnerships in this work, so for the medical students in particular, if you think about kind of your role as the clinician, the first thing is that you have to identify the partners and identify the need too. And so I would be remiss if I didn't tell you that community is not this lofty thought of this far off place. It's really the people that you're serving. And so really utilizing relationships that already exist. So Mark mentioned, he arrived here 2 years ago with tons of experience and expertise from Chicago, but didn't really know the Columbus community very well. So if I had to give you guys a playbook, if you will, of how to get engaged in the community, the first would be to find partners internally and externally. So I'll start internally. Many of you from a clinical perspective would probably only see me in a committee or something of that nature. And so you may not naturally think that there's somebody out there thinking about how to solve the problem for the patients that you're seeing in clinic. And I'll tell you, most institutions have people like me and Wanda Dillard and Chastity Washington and Diane Gordon and so many other folks across our health system who are thinking about the ways that we show up in the community every day. And so I implore you that you don't have to go it alone, and really you probably shouldn't start there. So you may see a patient in clinic and over you notice a problem that they're experiencing in the community. I would encourage you that your first step would be to look internally and find out who might be able to help you. And so, that's an example of what Mark did. He literally got in my car and we said, okay, let me drive you around a little bit, because we really need to understand the communities we're serving. And that takes time. The other thing is that there are external partners who are probably already doing what you're trying to do. And so whatever that idea may be, another first step as you think about the organizations you all will go on to lead is internal partners, but then also external partners. What nonprofits, what school districts, libraries, banks, and other community development organizations, who can you partner with to think about solving whatever this problem is? It's incredibly important to leverage social capital. So I'm going to be a Glenn College professor for a minute, and I probably spend 3 weeks in a lot of my classes talking about the wealth of social capital. This is not something you can artificially create, and relationships take time to build. So that both personally and professionally, when you're interacting with people in clinic and otherwise, that it takes time. And so if you're trying to solve a problem, you're gonna do best by connecting with networks of people who are already in relationship, and just understanding that building that relationship takes time. So the partnership piece is important because partnerships aren't always big, right? So PACT is one big thing that we've done. The community care coach is one big thing that we've done. But if you're wanting to engage with the community, it can be a one time a year, an ongoing thing. And frankly, your first step is to be in partnership with your patients. And so building those relationships in clinic, but then also building relationships in the community, leveraging other organizations and partnerships that may already exist. So I would always say, start from a place of somebody else has to be thinking about this. The other piece that I always say to people, and I think is really important, and certainly none of you would be pursuing this profession if you didn't have some level of empathy around the people that you're serving. I think especially in the context of today, and as you guys are pursuing your medical education, you're probably hearing over and over that you need to be culturally competent. And that is incredibly important. But I will tell you that cultural competence is just a recognition of things, right? Of the biases and really understanding the differences of experiences that people have. But cultural humility is the action and the behavior that you demonstrate in doing that. And so having a genuine interest in understanding the communities that you're seeking to serve and their norms and their relationships is really important. And it may not be you. So it may be one of those partners that's helping you understand that, but it's important to not assume anything about the communities that you're serving, the neighborhoods, and it's really kind of that human level connection. So I would be remiss if I didn't say that every chance I get, that competence is recognition, humility is action. And so really moving through clinic and your community partnerships in a way that is truly culturally humble is absolutely important. Frankly, it makes my job easy too, right? You guys are all training to be fixers. And so sometimes you may show up and I've got the answer. But remember, I told you in my introduction that the community has the answer too. They're the experts on their lived experience. And these relationships need to be reciprocal. And so you really have to honor that perspective. It is something that I think if you guys reflect on some of the things that Dr. Rastetter just shared about the history of community and health and the way and the why of how these things have been pursued, we've been talking about this for a long time as a community, as a society. And the reality is that I think right now we have a renewed interest in addressing the social determinants of health, which I think is incredibly important. This figure here is from the Robert Wood Johnson Foundation. I love this figure. I think it eloquently demonstrates kind of all of the dimensions of life that influence healthcare. So we know that health is far more than healthcare. It's the communities we live in and how we move through them and our opportunity for our families to seek optimal health and well-being, whatever that means for them. But importantly, as we think about leveraging these existing relationships, finding those partners, showing up culturally humble, we also have to recognize, again, that we should be working with the community. I can't say it enough. The community is the expert of their own experiences. So, Mark, you can go to the next slide.
And Autumn, I just wanted to, because I got a question, and just because we're talking about social capital, the question came in, how can students right now start to build social capital in their communities? Didn't know if you wanted to answer, and I had some thoughts too.
Yeah, well, you go first, Mark, and then I'll.
Well, yeah, when I see that question, I think it's incredibly important. I think there's a lot you can do. And I think and I'll be curious, when I think about it, and even myself as a student, there's two ways a lot of us come in to medical school thinking that we might be going somewhere for medical school and going back to somewhere else. And so in wanting to do real meaningful work while you're here, I think that when you're doing work as a medical student, you're carrying you're coming from an institution, from Ohio State. And so I think you build social capital by being an ambassador of the institution, but then you also build that personal, social capital if this is an area that you want to stay in a community you want to stay in. I think about some of the opportunity, even in volunteering, and Autumn, maybe we'll share in later slides there, could talk about just all the stuff that's going on with work in our high schools and in our feeder schools that medical students have that get involved in. Not only are you getting involved personally and potentially building relationships and building up potential future patients, but you're also bringing that the Ohio State background, and so it's helping future students build that social capital as a medical school. And I think that's important. Autumn, I'd be curious on your thoughts as well.
Yeah, I think that's absolutely true. I think it's funny that you mentioned that students may arrive here thinking, oh, I'm going to go do residency back where I'm from or some other community that they want to live in. I will tell you, I'm a testimony that doesn't always happen. I came to Ohio State a long time ago. I won't tell you how many years ago. And I never would have thought that I would still be here. And so really, I'll tell you my example of how I did it, and the way that I got to know the community. And so people always say, Autumn, you know everybody. And it's because I did start when I was a student. One of the things that I did was I volunteered. So everywhere that I could, I signed up to volunteer. It was a personal interest and commitment of mine. And so there probably isn't a nonprofit in Columbus that I haven't volunteered at once. And it was just something that I decided to pursue. Importantly, I did show up not as, here I am, this OSU student, and I'm gonna help you solve your problems. I showed up and said, how can I help? And where can I pitch in? And so volunteering in the community is the way I literally learned my way around both the people and the players and the institutions that were at play. But also I physically learned my way around Columbus by going to all these different places. As medical students, if you have an interest in something, there is probably someone within the institution that can help you get connected. So Mark mentioned education. I'm gonna share some of the things we're doing on the Near East Side at PAC from a place-based perspective, but I think showing up when opportunities present themselves and allowing yourself the wonder of imagining where you might help. It may not be in a clinical way. It may be sharing your personal experiences. It may be volunteering to serve dinner to different families, but I think all of those experiences do help you build what I described as cultural humility, because you get to see the places where your patients are being served. And so, I think it has to come from your own personal interest. So, whatever that may be. At the time, for me, I was very interested in things that were serving women and girls. And so I spent a lot of time volunteering with organizations like the YWCA Columbus. And so, I would encourage you in your non-existent free time to look for opportunities to volunteer. And there are opportunities that aren't ongoing. So it's not something that you have to make a commitment. Mark mentioned kind of our mass distribution. We have medical students helping to put together those community care kits. And but for having those student volunteers, and maybe some of you help with that, we wouldn't have been able to do that. And that was incredibly meaningful. They didn't get to interact with the community as much, but they were doing something along the stream. So building social capital is building relationship. And I think that's important. And also understanding that it's not going to happen overnight. So again, pick the things that you're interested in and, call me. I'm happy to help you get connected or, help you with some ideas about how to do that. So appreciate that question. Next. So we've talked a little bit, and Mark mentioned earlier that, the formation of community health centers were really being located into the communities where the need was, where those people were, and taking the healthcare to them. What we recognize though too is that, okay, so now we have health centers, we have hospitals located in communities, and the university is not in a city by itself. We've got our own zip code, but we're not in isolation. We're a part of a community. And so that recognition first, both as a land grant, but then also just physically thinking about what that means. I think I really am impressed constantly with the level of social responsibility we feel as an institution. And so there's lots of research about the role of anchor institutions. I'll say to you in sum that we have a responsibility to leave communities where we are in a better place. And it's more than offering healthcare. So we've done that for a number of years. I'm gonna share with you the PAC story in a moment, but that's one way that we're doing it. So as we were starting it, this is a quote from our president at the time, President Gee, where he really led the way with this. And I probably share this quote all the time because I think it really succinctly shares what we did. So some of the things that we talked about in building social capital, I'll call those lowercase p partnerships. So they're one-off opportunities, they're smaller engagements, they're infusing yourself into existing efforts. This is an opportunity where we took a big P and we made a bold statement about what we were going to do. So again, we have a responsibility to strengthen the communities, both in investing in those communities, and I'll share some of that, but also leveraging our human capital too. So students and researchers and really applying what you guys are developing and all of us are developing across the university into the community setting. And so that's a responsibility that I don't take lightly. And I think again, if you do end up leaving Ohio State and you go somewhere else, that's also a place to start too. Think about where the hospital is located and the status of the people around that hospital. So next slide. So we did that through our nonprofit affiliate called PACT. And so PACT is an acronym for Partners Achieving Community Transformation. We leveraged civic engagement to develop an investment plan. I'll tell you, going off of my previous note around kind of the role of the anchor institution, if you haven't been to East Hospital yet, which is behind Mark there, on the Near East Side, we've owned that hospital as an institution for about 20 years. And so in 2010, we formed a public-private partnership with the City of Columbus and the Housing Authority to really look at the community surrounding East Hospital. And Outpatient Care East wasn't there yet. At the time, Outpatient Care East was a vacant VA hospital, and we were planning to renovate that to become this outpatient care facility, which is now wildly successful with more than 1,000 patients seen per day. But really addressing that medical need was a first step. We had the hospital in the community for many, many years, but when we looked at the data of that community, and so this is going into the social determinants piece, the community was not better off just because we were there. So there were high levels of vacancy, high levels of unemployment, lack of access to fresh produce and other food options. The schools were failing. There were many things in that social determinant wheel that was failing. And here you have this flagship university as the anchor institution in the middle of the neighborhood. And so while we were partnering with the city and the Housing Authority, I think Ohio State felt even more of an impetus to move forward and thinking about how do we leave this place better. And so we formed this partnership in December of 2010, really with the idea that we would develop a plan, right? So Ohio State, the City of Columbus, which is the municipality in which it's located, and the Housing Authority, which is our local public housing authority that really is responsible for providing affordable housing to the least of these in our community. Those three partners all had a vested interest in what would happen in that neighborhood. And so we thought, we're going to spend a year, we're going to engage the community, and we're going to come up with a plan for investment. I always tell people I was working in Bricker Hall, minding my business, and Dr. Gee came to my office and said, I heard you're going to the Near East Side. I had no idea what he was talking about. Frankly, I didn't think he knew what he was talking about. A couple weeks later, I was given a one-year assignment to help shape what this plan would look like with the community. Now, I told you guys it was 2010. Here we are in 2020, and I'm still there. And part of that is truly a blessing on my career and my life personally. But part of that is as we started to engage the community, we had a recognition that this was much more than what we originally thought. This is a community that had not been engaged. We certainly had relationships with the community. Our annual Healthy Community Day had been going on for a number of years. And we did a lot of smaller P partnerships, but we had never looked at how we might help shape what housing and education and safety looked like in this community. So it took longer than a year. About 6 months into it, we realized that we owed it to the community to have this conversation in a more distinct and clear manner. And so we spent about 18 months doing community engagement with the community. Again, I told you before that the key to this is to co-author whatever's going to happen with the community. And so we spent that time. What we developed is a plan for the community that focuses both on kind of the physical change. So at the beginning, there were nearly 700 vacant and blighted parcels in the community, and only about 7,700 residents in an area that could fit about 40,000 people. And so from a planning perspective, it was ripe for redevelopment, but we wanted to make sure that that was thoughtful and inclusive of the community. So physical development and real estate and really thinking about the place physically. But importantly, I think the majority of our plan is programmatic in nature, recognizing that people's lives are multidimensional. And so we need to address all these factors at the same time. So it's not enough to fix healthcare and make sure they get personalized healthcare. It's not enough to look at the housing. We also have to look at the education system and those sorts of things in the community. So the plan is up on our website. Actually, this link goes right to it. And so if you're interested, it's a very well-written document, if I don't say so myself. But importantly, and what I'm most proud of, is that it was developed through community engagement. So I was trained to write master plans for neighborhoods. I could have easily looked at this community on a map and read some data from the census and other sources of information and developed a plan, but that's not how we approached it. We approached it through conversation and partnership with the community. And what we ended up with is really this holistic approach to addressing all of those dimensions of social determinants of health. So our focus is on mixed income housing, that this will be a community that has housing available for everyone who wants to be there and who wants to stay there. And I'll talk to you about the ways that we're doing that. A cradle to college and career education pipeline, and really a focus on community wellness, recognizing that, again, wellness is more than healthcare. It's really the opportunity to seek the best life for yourself and your family. So next slide. So in implementing that, and these are some pictures of some of our community engagement, literally engaged thousands of people over this period of time. I'm so proud of this plan because the people who live in this community and the stakeholders we engage, they can tell you what's in the plan. So it is a living document. It's not something that we developed and we just checked it off our list that we did this, but these are initiatives that were born out of that plan. So I'll give you a few examples of some of the signature programs that we're doing through PACT. With the community, and then we'll open it up for more questions, and we could talk about all of these topics for hours at length. So the first one is that we launched an OSU employee homeownership incentive. So in our community engagement process, a lot of the community members said to us, put your money where your mouth is, OSU. If you really believe in this community, you should be telling your faculty and staff to live here too. And so we did just that. So we launched a down payment assistance program for faculty and staff at the university to purchase homes. We give down payment assistance in the form of a grant. So you have to live in the home for 5 years and it falls off of your deed over time. When we launched the program and I was preparing this proposal, Dr. Drake really pushed me because I even after working in the community for 7 years at that point, I was like, we do great to get like 5 people a year maybe. And of course he said, we need to do 10 every year. We need to do 10. Programs like these are not unique to Ohio State. There are other institutions who do them. But for us in Columbus, I mean, we're really leading the way and thinking about putting our money where our mouth is, if you will. I will share that since we launched this program, we get on average 10 people a year, sometimes more than that. We actually have had a closing every week for the last 4 weeks. And so faculty and staff have really latched onto this program, excuse me. Again, one of the things that I'm proud of, and it's something that we measure, is that it's not just physicians and nurses, it's staff at all levels. And so we have people who are instructors and work in the cafeteria and you name it, who have really decided that the Near East Side is a place that they want to call home. This is an important element to creating mixed income housing, and that there are home ownership opportunities and the opportunity to invite new people to live in the community. This is not intended to push anyone out, and frankly, it hasn't been. I think I shared briefly a little bit of the vacancy. There is still room in our community for folks to come in. The companion, I would say, program to that is our exterior home repair program that we started 3 years prior to that incentive, which is us literally giving grants to existing residents, both renters and homeowners, to make exterior improvements to their home. So again, in that community engagement process, we heard loud and clear from people that they wanted to feel like they benefited from this change. They didn't want change to be happening to them. They didn't want people to be coming in their community and they weren't benefiting from that change. And so we started this program in 2014. We managed the program with the homeowners. And so a huge part for me is always to teach people about whatever we're doing. So even with the homeownership incentive, open to the community, but importantly, our employees, is financial fitness and home buyer education. The same thing with our exterior home repair grants. We give our grantees the opportunity to learn about home maintenance. And if any of you are homeowners, you know there is a lot of nuance to taking care of a house. And so we provide these grants again to the community so that they are able to benefit from the transformation and be a part of it. And so this is a program that we are actually right now looking to grow and scale. Another initiative of ours, again, people think about where they're going to live based on the schools in the community, whether or not they have kids. And that's just kind of proven planning theory and the way that communities develop. This community already had a complete feeder pattern. So a high school, middle school, and 5 elementary schools, which is actually not the norm in Columbus. So it was something that we felt was an asset. It also is a historically important feeder pattern to our community. And so we could have gone a lot of different ways. We could have said, Ohio State's going to build a charter school. We're going to do something else. But importantly, through community engagement, we decided that the right and the best thing for this community was to partner with the existing schools. And so we launched the Health Sciences Academies, and it is pre-K through 12. So it's all 5 elementaries, the middle school and the high school. That's a perfect opportunity for engagement. We have lots of engagement with faculty and staff and helping to write curriculum and doing guest speaking opportunities and all sorts of endeavors there. It's important to us too that people have opportunities to be economically mobile. Part of that is education. Another part of it is entrepreneurship. And so we're going to be launching in a few weeks an initiative called Venture Suite that should have launched in March, but COVID, but is really focused on helping people who are interested in starting businesses that are tech focused. There's a huge Black tech movement here in Columbus in particular. So I look forward to sharing more of that later. Safe, vibrant, and accessible neighborhoods was one of our working groups in our planning process. And this was one where it was important for us to understand that the perception and actual safety is really dependent on the community having social capital within itself. And so we're not here to lead people and tell people what to do, but we do want to help empower people to think about how they can change their neighborhood. So I often have city council folks and other people say, oh man, Autumn, you explained this to them and now they're coming out here asking us these questions, but that empowerment is really important. And so we actually have a neighborhood leadership academy where we train people, one, on the history of equity and race and how it's influenced the way our neighborhoods are, but we also want them to understand the political and civic process and how they can plug in, because we have folks who have lived in our community for 5 years and 40 years, and everybody has a role to play. The last 2 things that I'll cover really quickly and then we can move to question is that when you think about a community that you're coming into to help shape, it's important to acknowledge both in action and in word that the community already has culture and identity. And so we have done a number of things over the year, a film series, what we call NESHOP, Near East Side Hop. We sponsor organizations like the Maroon Arts Group and a number of organizations who are doing things. And that really is from a principle around self-determination, that communities really can identify who they are in themselves. We're actually planning a celebration parade in October. You know, hopefully Mark tells us it's safe to do so, celebrating the history of this community as one Bronzeville in the nation. So this community is rich in legacy and identity. And so it's not our place to try to recreate something, but really to honor that heritage and really think about how it fuels our future. Finally, one of the most important things that we've been able to do is win some money to help fund this work. So we are one of 3 communities in 2014 who got a $30 million HUD Choice Neighborhoods grant to implement some of that work. And so this was a wonderful opportunity for our community to see. They gave all this input and then we took that master plan and applied for funding. The majority of those dollars have gone to the redevelopment of Poindexter Village, which is a public housing site behind East Hospital. But additionally, it's helped fund things like resource navigation for the public housing residents, and that sort of thing. So as we think about kind of the future of our work, this has been one major task that we've completed, and that development will be done at the end of next month, which is 26 acres of redevelopment. It's not a small undertaking. We will be one of the first cities in the country to complete our redevelopment. There are cities that started before us with the same grant. And so that really speaks to the leverage of partnership and that sort of thing. So that's a little bit about PACT and kind of partnership, but I think if I would say anything, it's really acknowledging the community as it is and seeking to understand what those needs are and what your unique gifts and talents may be to help solve some of those problems. So you all can feel free to raise your hand, type in questions in the chat. Hopefully this was interesting to all of you, but we really appreciate the opportunity to share some of our work.
And Rosevine, if you don't mind unmuting, or whomever raises hands, that'd be great. I don't know if I can do that.
Can you hear me okay?
Yes.
Yes. I did it by mistake. I was going to write in the chat, but since I'm already, I'll go ahead. I'm very interested in some of the community approaches that OSU has developed, and I'm in the DNP program right now at the College of Nursing, and just fascinated by some of the public health information we were working on. My concern is number one, I'm an individual, and is there any way for individuals to make an impact rather than what we seem to see as policy and federal, state, and money and housing and things like that. So on an individual basis as a clinician. And number two, as a member of a white privileged sector, is it possible to be able to work with a community that may not always trust you and the history and so forth? So two questions for you at this point.
So I would say, and Mark, please feel free to add on to this. Yeah. As an individual, particularly as a clinician, your first opportunity is in clinic, and building that relationship with your patients and seeking to understand what's influencing and impacting their health. And so that's a very easy and incredibly important way that you can make impact as an individual. So, you may see someone who in clinic who may not have had a positive provider relationship, or someone who has taken interest in them personally. And so whenever you can build those relationships, I encourage you to do it, because it's going to be a reciprocal benefit. One, it's going to help you better understand them so you can better serve them, but it's also going to make them feel heard. And obviously I haven't gone to medical school, so who even knows if it, or even nursing school either, who even knows if they're teaching you how much time you have to do that. But I would be remiss if I didn't share with you that building that relationship and listening to your patients is an incredibly important part of helping to help shift the community and building that relationship with them. So that's really important. I would say as an individual too, I always tell people the one thing that you can do, and I say this to my students, so luckily none of my students are on here and they won't be sick of hearing me say this, is that I implore you to cognitively engage in the community around you. And so wherever you live and where you work, whether it's reading the paper every day, really be thoughtful about how you're consuming the information and understanding what's happening in the world around you. Again, that's going to influence your understanding of what your patients are seeing. And then voting. I mean, that's one individual impact. And then from getting engaged into things that OSU is doing, individuals can volunteer. I mean, Mark, literally, this is a true story. Mark came to me and said, I really want to understand how myself individually and our department can get engaged. And so we formed a relationship one-on-one, and I helped him navigate that. That is my entire job. I'm not the only person who does that, though. And so there are people who can make connections for you individually. I think it's important for you to decide what it is that you're interested in. There's plenty of need for you to engage individually and as an institution, but importantly, one way is to just be engaged in what's happening around and it may be reading. Trust happens over time. And so it's something that it's good for you to acknowledge that there may be a barrier of trust, but the way you build that is through relationship. And so, you know, even though I'm a Black woman and I grew up in a community that looks very similar to the Near East Side, I had to build trust with the community over time. And so from a planning perspective, I always say, you know, if I don't know, I say I don't know. That builds trust, right? But then also I do what I say I'm going to do, and I'm consistent in that. And that, again, happens over time. But then you latch on to a trusted broker. So it may be a contact at the university. It may be a nonprofit leader that you're volunteering with. But recognizing that there's somebody who may have a relationship that you don't, and how can you leverage that to give your unique talents, time, treasure, wherever it may be. So
yeah, no, and I agree. And I think we probably have to leave for the next session, but I agree. I mean, it's a lot of that. You mentioned policy, and it's that upstream and downstream, right? We have to look at the upstream policy implications and advocating and acknowledging, and then that very downstream, you know, stethoscope on the chest, listening to a heart, acknowledging the patient, and then talking to them and asking them. And I think in the community too, asking patients, you know, where they go grocery shopping and showing up. Autumn and I were chatting about this a little bit, that, you know, a lot of times you have a group of providers that don't live in the community of which they serve. And so how do you see patients? You know, it used to be, you know, 50 years ago, the doctor was, you see him grocery store, see her at the grocery store, whatever. And so I think that, especially coming from a place of privilege, you have to always check your bias and check why you're coming into and why you're asking the question and why you're actually wanting to do an intervention. And then rethinking it, you know, because oftentimes we come in from that place of privilege to like drop in and say, I know what we need to do for you. But then just showing up in little things and getting involved. And I think of all the phenomenal physicians that have been involved in the health sciences academies, for instance, that just show up and do one-on-one mentoring with a high school student. When people see that, parents see it, teachers see it, principals see it, and then they start to understand where your ambitions are. And that's just created, that's that social equity, or however you wanted to frame it. It starts small and you know, into process over time. So that's just briefly a little bit, but yeah.
We didn't get to all the questions, but
yeah.
please feel free to email us. I know there were some questions about the health sciences academies in particular and engaging. Please reach out. I'd love to connect with you and share more. But thank you again for being engaged. And go ahead, Mark.
No, I was just going to say, we're both on Twitter. Those are our handles at the bottom. Autumn's always putting out phenomenal stuff. I'm usually retweeting everything she puts out. And that's mine. I try to put out things that are coming from the department, or especially in family medicine and social medicine circles. So, but please definitely connect with us. We look forward to continuing the conversation.
Great. Thank you.
Thanks, everybody.